Well, welcome everyone. My name is Dan Florizone, and I'm an executive in residence with the Johnson Shoama School of Public Policy. I'm also pleased to be the moderator for today's session. We're pretty excited. I think we've broken a record here for the number of participants on this Zoom call. My number is proved right, and everyone who signed up shows up. Will be over 190 participants. So the logistics are going to be interesting, and I'm just so thrilled to act as moderator. So a bit of background to begin with on the school. The Johnson Shoama Graduate School of Public Policy, or JSGS, is a provincial center for advanced study and research in public policy administration. We're a partnership between the University of Regina and the University of Saskatchewan that was based on the spirit of cooperation and collaboration that really defines our province here in Saskatchewan. Since our inception in 2007, we've swiftly become one of Canada's leading policy schools for educating graduate students and public servants interested in and devoted to advancing public value. At this time, I'd like to acknowledge that while today's event is taking place online, JSGS, our physical home, is located on Treaty 4 and Treaty 6 land, and is also the traditional homeland of the Métis. To help our event run smoothly, we ask that all attendees stay muted and turn off their video during the presentation portion of our event. Feel free to turn your videos back on for the question and answer period. So just in the spirit of describing the format, today's event, our speakers will present for about 30 minutes. The two of them will trade off. Following the presentation, our panel will entertain questions. I think this will become a very interesting Q&A portion. If you'd like to ask a question, you'll note I've left on the chat feature a note to you. Please use Zoom's chat function to send your questions to me, Dan Florizone. Please indicate whether you'd like to unmute to ask your question or whether you'd like me to ask a question on your behalf. I'd be pleased to do so. And we'll see how this goes. I will call on you when it's your turn to pose your question to the panelists if you wish to ask the question yourself. We'll see how this goes. If I have to, I may have to take over asking questions, just given the sheer number of participants. Now, if you're having any logistical questions during the presentation, don't hesitate to send a message to Karen Jaster LaForge via the chat function. Please note that as with all our public lectures, this presentation is being recorded and will be available for viewing on JSGS website, on our website at a later date. So now, with that formality out of the way, I'm pleased to introduce to you today's panel. First, Michael Nicin. Michael served as Chief of Staff and Senior Policy Advisor to the Ontario Minister of Seniors Affairs. During that time, leading to the design and launch of the $155 million provincial seniors strategy. This is the first government-led senior strategy in Canada. He also served as the Senior Policy Advisor to the Ontario Minister of Children and Youth Services, where he oversaw the design and launch of the $500 million Ontario Autism Program. Prior to this, he also served as the Director of Policy and Strategic Planning at CARP. CARP is a 300,000 member-based advocacy organization for older Canadians. He is currently the Executive Director of the National Institute on Aging, and we're so privileged and pleased to have Michael join us today. Dr. Samir Sinha, for those of you familiar with his name, I know that many of you will be. I just found out just this afternoon that he's originally from Winnipeg, so we know he's good people. He's a good guy. Dr. Samir Sinha is Director of Geriatrics at Sinai Health System and the University Health Network in Toronto, and Associate Professor of Medicine at the University of Toronto and Johns Hopkins University School of Medicine. Samir is a Rhodes Scholar. He's highly regarded as a clinician. He's an international expert in the care of older adults. He has consulted and advised governments and healthcare organizations around the world and is the architect of the Government of Ontario's senior strategy. In 2014, Maclean's magazine proclaimed him to be one of Canada's 50 most influential people and its most compelling voice for the elderly. So we're looking forward to a very interesting and engaging discussion this afternoon, and I'm very pleased to turn the floor over to our speakers. I believe, Michael, you're up.
Please. Thank you, Dan. Thanks for the generous introduction and for hosting us, and also to the Johnson Shoyoma School. And thank you to everyone online who has taken a couple of hours of your afternoon to join us. Really looking forward to the Q&A after the presentation. And with that, we'll start with the presentation. Samir, if you could advance the slide. A little bit further. Perfect. So a little bit about the National Institute on Aging and where we're coming from. The NIA is still relatively new. At some point, that designation will expire, but we were established in 2016 at Ryerson University, specifically to provide evidence-based public policy innovation and advice, and to promote best practices for aging well. So we work with governments, with industry, both public and private, and we work with the broader community and NGO sector, really with the mission to make Canada the best place to grow up and grow old. In addition to working on policy issues, we look at best practices clinically and financially, and really try to merge everything into steering Canada towards a future that has a deep respect and policy innovation for its aging population. To that end, we are currently, and always stand for correction, the first think tank focused exclusively on cross-disciplinary research, thought leadership, and innovative solutions, public education, and policy on aging. It's a big mandate, but we recognize that any of the issues that we're touching upon have multiple intersections with others. So when we're talking about healthcare, we have to talk about how it's funded. We have to talk about Canadian socioeconomic status. We have to talk about social well-being. And so we take a comprehensive approach to all of the issues that we tackle. Next slide, please. So the learning objectives for today, I'll lead us off with a couple in terms of the background of where we are with long-term care in Canada. And then we'll kick it off to Dr. Sinha, who's going to go through the lessons learned through COVID and where we need to go into the future. So the first objective is to understand systems of long-term care. It varies across the country. Most of us live in provincial budget bubbles, and so we sort of see the landscape from our own backyards. But when you look at Canada, it's a large, complex, multidisciplinary, multi-jurisdictional society where long-term care is often fragmented depending on where you live, and sometimes even within provinces. So we've done some work looking at this total state of long-term care in Canada, and I'll catch you up a little bit on some of our previous work. And then where Dr. Sinha will take over is understanding the epidemiology of COVID-19 in older adults in the community and in residential care settings. Understanding why Canada has experienced some of the highest global rates of COVID-19 deaths in its residential care settings. And finally, how should our COVID-19 experiences help accelerate how we consider the future delivery of long-term care? I think everyone on this call would probably agree, at least as a starting point, that our current systems of long-term care are not meeting the needs and the dignity of our older people, and we have to do better. Next slide, please. So last year, even before COVID-19 hit, Dr. Sinha and I and the rest of our team decided that we wanted to take a deep look at long-term care in Canada. Every year, the NIA tries to find a subject to coalesce around to look at from multiple perspectives. And last year, we started looking at long-term care. So in our 2019 policy series, which was sponsored by and produced in collaboration with Advantage Ontario, the not-for-profit association representing long-term care in Ontario, the Canadian Institute of Actuaries, who incidentally have the coolest acronym, if it's the CIA, but not the American one. The Canadian Medical Association, which of course represents doctors across this country, Essity, and Home Instead Senior Care, which is a leading player in home care delivery in Canada and globally. The purpose of our inaugural report of this series was to, number one, explore the current provision of long-term care across Canada and place it within a global context of comparable countries that are tackling similar demographic transitions. So it's, of course, one thing to understand long-term care in Canada, but a comparative approach is essential if we're going to learn about best practices that are happening elsewhere. Oftentimes, you know, we as a society and as an institute and governments, I think we should avoid trying to recreate the wheel, and where possible, poach the best ideas from people who have proven that they work elsewhere. Number two, we want to highlight Canada's current challenges. I think last year when we were writing that, we had a pretty good sense of what the challenges were, and if we didn't, and if anyone else didn't, I think COVID has thoroughly exposed what the challenges are to delivery of long-term care in Canada. And finally, in the first report, which I should mention was written by Dr. Samir Sinha and his team, it presents that evidence-informed opportunities and enablers for innovation. So even last year before COVID, we were looking at a fragmented system, a system that lags in comparison in a number of ways to international leaders such as Denmark, which Dr. Sinha will talk about. But we wanted to have an optimistic vision and say that as many challenges as we have, there are opportunities and enablers to improve the system. And our hope in the dire situation we find ourselves in now is that COVID will give us that tipping point to actually affect real change in long-term care across Canada. Next slide. The second series in our report was written by Dr. Bonnie Jean McDonald. She's an actuary by trade, and she was joined forces with John Hurdes, who is an expert in assessment in medical health care in general, and Michael Wolfson, who's a former ADM at Statistics Canada. And what they did is wanted to understand where, given the status quo, again, the pre-COVID status quo, what are the funding scenarios in long-term care that will potentially restrict our ability to innovate radically, or that we have to pay attention to as we innovate, understanding that there is not amounts of funding available to do everything we want to do. So we really want to understand what the funding and fiscal reality is of long-term care. And as you'll see as we go through, the situation wasn't very great before COVID. We're looking at a system of long-term care that's catching up to demographics after decades of underfunding and to some degree neglect. And even in that case, even again before COVID, where a lot of us would agree there was underfunding, there was perhaps a less cohesive approach across the country to how we fund long-term care. Even there, we saw major red flags popping up in terms of the funding and the sustainability of long-term care. So I'll get a little bit into that report going forward, and then certainly have more opportunities to chat about it as we progress through this session. So the first question we asked ourselves is, why does long-term care matter? As we note in our reports, it's the largest form of hands-on care that is not covered under the Canada Health Act. So without belaboring the point, many of you will know that when we instituted universal health care in Canada in the 1960s and 70s, our population was on average 27 years of age. Today we're closer to 42. We also didn't live as long as we do right now. And I think it's to an extent fairly understandable that at the time we focused on primary care and acute care, but we did not account for long-term care. And to some extent, we're still sort of paying for and catching up to that omission. We're also noticing the coverage levels, qualifying criteria, and design standards vary significantly across the provinces and territories, something that's also in contrast to our hospital sector. There's a growing value of these services to meet the long-term care needs of an aging population effectively and sustainably, but without a cohesive approach to it, we're seeing provinces struggle individually on their own. And we're also seeing that the current demand for long-term care services is already unprecedented. We'll get into some of those numbers there too. But of course, because we're catching up to our demographics, we have a long wait list for services, but we're also expecting that to grow as the population ages. And finally, on this slide, the system has been plagued with longstanding systemic vulnerabilities. That's a term we weren't loosely using before COVID, but I think COVID really has exposed these systemic vulnerabilities when it comes to its health and human resources, physical design, and redevelopment approaches. And as I say, we'll get into some of the nuts and bolts of those three issues in particular as we go forward. So this is a slide Dr. Sinha could speak to more later on. But what we realized in the early stages of our series report is that even the term long-term care doesn't have a common definition across Canada. You know, if you're in Ontario, long-term care, typically the association is nursing homes, not home care. If you go to other provinces, there's different definitions for it. So the initial challenge, as basic as it sounds, was, well, if we're going to understand long-term care in Canada, we need a common understanding, a common platform to begin with. So we actually approached it with the international lens, which is that long-term care is the full continuum of supports that people need as they age, whether it's a few hours of home care, support with groceries and that sort of thing that allow people to age and maintain their independence in community for as long as possible, all the way up the chain of retirement homes, nursing facilities, palliative care. So when we talk about long-term care in our series, anywhere we go, and including in this session, we're really taking the broadest approach, which is that long-term care is that broad, comprehensive continuum of care needed to support people at various stages of need. So whether, again, a few hours here or there or full-time care, that's how we approach the definition of long-term care in our work. Next slide, please. Yeah, so a little infographic here to contextualize where we are, again, pre-COVID. So over 430,000 Canadians currently have unmet home care needs, while 40,000 are on nursing home wait lists. So, I mean, this is fairly self-explanatory, but the other way to look at this is that we have almost 500,000 Canadians who are living at home with some semblance of independence, but are probably at risk of tipping over into a higher level of care need because their needs are currently being unmet at home. And then, of course, despite the sort of target on nursing facilities right now, there are about 40,000 Canadians who are on a wait list to get into a home because they cannot be supported properly at home, given the current arrangements of our long-term care systems. And as a sort of international comparison, to put Canada in comparison with other countries, you'll see here towards the right side of your screen, that Canada spends relatively less of its GDP on the provision of long-term care than other leading countries. So again, on the far left of the screen, you'll see that the Netherlands, Sweden, Denmark, they're all spending north of 2.5%. Netherlands, of course, leading at 3.7%, and Canada's only spending about 2% of its GDP on long-term care. So we could, obviously have endless debates about what the right amount is, but when you do the math on what's happening in long-term care right now, the wait lists, the unmet care needs at home, it's fairly evident that Canada is underfunding its systems of long-term care. Slide, please. Thank you. And comparing to other OECD nations, Canada also spends far less on home and community care than on nursing home care. So if you could see this clearly, for those of you who have your screens open, the dark colors are nursing home care. The sort of intermediate blue is home and community care. And then the sort of lightest color is other. Omitting other for now, you'll see that Canada on the right side of your screen spends about 87% of its total long-term care budgets on nursing homes, so on facilities and institutional-based care, and a relatively paltry 13% on home care. If you go all the way to the other end of the stream, you'll notice that Denmark pops out in contrast on both of the slides that we just looked at, both in terms of its GDP spend and its proportional spend on home care versus nursing homes. So not quite inverse of Canada's, but getting pretty close. Denmark, on the other hand, spends about 36% of its long-term care funding on nursing homes and whopping 64%. And then, of course, when you get to Finland and Poland, it's even bigger. So where you start to see is a picture where certain countries are investing more in long-term care, and they're also investing more in the kind of care that people want, which is, quite clearly to age at home independently with their families and in community for as long as possible. And as Samir will indicate, this is not to say that nursing homes aren't going to be necessary for some number of older Canadians, but I think it's on the surface fairly evident that most of us would prefer to spend time with our families as we age in our own homes and communities, and Canada's spending ratio doesn't reflect that. So to get to some of the projected costs of long-term care over the next 30 years, what Bonnie Jean was able to do in her report is show that over the next 30 years, again, pre-COVID, just based on the pre-COVID status quo, we're actually looking at a tripling of costs in long-term care, even if we did nothing. So growing from about $22 billion today to $71 billion in the next 30 years. And that's, again, if we don't effect any change. So now we start to see where some of these funding constraints, as low as they are, will need to be increased quite a bit in certain areas, certainly in the public sector, to account for the growing demand for services. And for those of you who like graphs, I'll make a special note of the top dotted dot, the public long-term care cost as a percentage of provincial, federal, personal income tax revenue. So right now, long-term care costs account for about 9% of that total federal and provincial personal income tax revenue. But again, only maintaining the status quo, accounting for variables like population growth, the fact that we're having fewer children, which means fewer family members who could potentially support us, families living farther apart across the country, the fact that we're all living longer. We're going to see that ratio of federal and provincial personal income tax revenue grow to about 20% in 30 years. So even without the impetus to change the system, to fundamentally reorient things at the pre-COVID levels, we're looking at fairly substantial increases in costs just to cover the bare minimum. Next slide, please. Yeah, so this reiterates that point there. So you can see 22 billion to 71 billion. That's in constant 2019 dollars. And of course, that's Canada-wide. I think the other thing that's very important that we can't forget, and we're certainly seeing that now with COVID and the lockdown, the separation between families, is that in the same time period, the 30 years, there will be approximately 30% fewer close family members available to provide unpaid care. So traditionally, we've relied on each other, on ourselves, on our family members to provide a lot of care. I think a lot of Canadians would still do that, willingly and happily. But again, because of demographic factors, there's just going to be fewer of us to support our older parents and siblings and so on as we continue to age as a population. And again, by 2050, the average unpaid family caregiver, and just for those of you who might be new to that term, we're calling unpaid family caregivers. Those are those of us who support each other. It's not informal work, as we like to say, because it's substantial, the amount of support the family members offer each other. They're a significant part of the care, but they're just not paid for it. So that's why we use that term. But those people in the community will have to increase their efforts by 40% over that period, just to keep up with the level of care that we're currently getting from our unpaid caregivers. So, or another way to put it, we would need 40% more caregivers to provide the same amount of care that we're getting now. So clearly we're sort of seeing, fiscal and funding constraints, but we're also seeing future projections on the kind of constraints where Canadians will be able to help family members age independently at home. Next slide. Okay, and I think this is where I'll turn it over to Dr. Sinha.
Thanks, Michael. So just carrying on, is that, understanding that some of the challenges that Michael just talked about in terms of thinking about, the different definitions, the lower jurisdictional spend for Canada versus the rest of the country. And then you see that there's even greater levels of variability that occur at the level of each province. But in the broad strokes of it, we found that there were 4 significant current challenges in the provision of long-term care in Canada. There are challenges that are faced by older Canadians themselves and their unpaid caregivers. So older Canadians who just cannot, and unpaid caregivers who cannot get the levels of home care support they might need in their own communities, that might actually therefore force a premature level of institutionalization occurring. But of course, if we want to provide people the ability to age in their own communities or in their own homes, we have to figure out how best to do that as well. We also know that those who are actually providing the care, so that we call paid care providers, but also unpaid caregivers delivering the care, often have their own challenges that they're facing as well. And partly it's just in terms of how we've created some systemic vulnerabilities. Often many of those who are working, providing care, tend to be racialized women and who are being paid close to minimum wage in some circumstances. And Saskatchewan is actually quite unique in Canada in that actually what a personal support worker or nurse will make working in a long-term care home, a nursing home, if you will, or working in the community, it's, as I understand, the same wage rate as their colleagues would make in a hospital. If you go to a place like Ontario or most of the country, you'll find the further you walk away from an acute care hospital setting, you'll be paid a lower wage rate doing the same work as in a long-term care or nursing home, and even further less if you're doing work in a person's home. So but pay is not the only issue. It's also other ways in which we organize and we structure people's work and support that often makes it very hard to recruit people into these areas of work and also retain them as well. We also know that the way we organize and we deliver that care tends to actually be quite problematic in terms of how we structured our long-term care systems. And again, we have a system that is more built on institutionalizing people rather than trying to be organized in a more preventative way and a holistic way that actually, in many cases, is actually cheaper to deliver and more in line with what people want. And then we also have challenges with how we even finance the care that we actually provide. So as Michael was noting, not only does Canada spend 30% less of its GDP than our average OECD countries, but also when you start looking at how we actually organize care, how it's actually paid for, there are varying different models, some that are using tax credit systems, others that are just saying it's free at the point of service, it's just highly rationed. There are many different angles that we have from that point that makes this very challenging area to do. So we spend a considerable amount of the report walking you through those pieces. When we talk about, what could the future look like? What are those enablers and opportunities to support the future provision of long-term care really across that continuum? We talk about that there's a great deal of good evidence-informed standards and policies and models out there that really could help us move towards a person-centered system of long-term care. And this is building off of the work that the World Health Organization that has really done a lot of forward thinking about what long-term care needs to look like. And is certainly more person-centered and integrated than what we see being delivered across Canada. Also, how do you actually support system sustainability and stewardship? So Michael was alluding to a little bit that right now, the current way that we're providing care is not really sustainable, especially if we just keep doing the same thing. So how do you actually organize care and develop a system in such a way that it can be sustainable? And that we can actually make it last for generations, but even provide more of the care. Because some of the calculations that Bonnie Jean and her colleagues did in their report was really looking at if we were actually to pay people working in these settings better, well, that's going to significantly increase the cost projections overall. And there are other different things that we need to take into account that we need to also understand that these are the sorts of things that will influence how sustainable our current systems or our future desired systems really are. We also talk about promoting the further adoption of standardized assessments and common metrics. So something that unites Ontario, for example, BC, Saskatchewan, Alberta, Manitoba, but not Quebec, for example, is that everybody who's receiving home care or care in a nursing home in these jurisdictions is all being assessed and monitored using the same standardized assessment systems known as the inter-eye assessment systems. So these are assessment tools that I can compare the rate of inappropriate antipsychotic prescribing in Saskatchewan versus Ontario, or it looks at everything. And these are also assessments that actually assist with care planning as well. But you can imagine when you start having comparable data, you can actually start looking at how we are doing jurisdictionally with one another. And we can see that there are significant jurisdictional variations in the quality, but these are ways in which we can start moving forward in terms of better providing care, but also looking at how we actually are organizing that care as well. And then what are the policy levers that we actually have that we can enable the long-term care reforms in line with what we want? And so this is where we went in specifically to talking about that in the report. It's a very hard graphic to read, especially if your eyesight is limited, and mine isn't great either. So, but this is a diagram that we have, I believe it's on page 77 of our report, which is basically a conceptual framework supporting the future provision of long-term care. And I'm not going to go through this in detail. The final slides of this presentation for reference are really breaking down and showing you what those individual small lettered things are. But really, this is really talking about thinking about care for older Canadians, if you will, or Canadians in general across the continuum. So on the right side, if you will, of the pyramid, if you will, we talk about the living environments that we could think about. So we think about people who are living independently as older adults in the community, all the way to people who are living in buildings where they need to receive their care. on the far left of this diagram, we see the characteristics of populations. So when we think about long-term care, we thought about a conceptual framework that thinks about healthy older adults with minimal care needs. So these are people who are living healthy and independent lives, but they're all at risk, for example. So what are the preventative approaches we can do? So this is where we think about government policy approaches like age-friendly communities. How do we think about things that can help people stay healthy and independent in their own communities? And then you start thinking, as you go up the diagram, if you will, we start talking about innovations that again can help enable people to stay in their homes as close to home as possible. And that's what we work on in our work. So this just gives you a sense of what we do. But of course, then came COVID-19. And with the coronavirus came a lot of new questions around the security and the stability of our long-term care systems in Canada. And so that's what I want to finish the presentation focused around. So right now, we know that COVID-19 has a predilection for the old in our society. So most viruses, if you will, affect those with less developed and weakened immune systems. So we naturally worry about young people in our society, those whose immune systems are still developing, and hence why we have a strong vaccination program for young children in our society. We also think about people of all ages who might have chronic diseases, which further increases their risk. And there was a recent study that was just published, I believe it was in the Lancet, that showed that those who live with chronic illnesses have a 12-fold greater chance of dying with COVID than those who don't at the same age level. And then we think about older people, because older people also have something called immunosenescence that they experience, and they might be more likely living with chronic illnesses. And together, those things actually increase your risk of actually dying of this. So not only do older people have that risk of having chronic illnesses, but just by the virtue of age and the fact that their systems will naturally weaken as they age, we start seeing a real variety of case fatality rates. So for those who are less than 18%, we say less than 1% of people are at risk of dying of COVID-19. In the general adult population, we're talking about 1 to 2%. And remember, ladies and gentlemen, 1% of Canadian society means 380,000 people. So we're talking about between 380,000 to 720,000 people, could die of COVID if every Canadian got COVID. This is why herd immunity, by just letting it sweep through our society, it's an option we could choose, but we just have to figure out, some of us could be part of that, up to 720,000 people who could die. But most of the deaths, of course, will occur amongst the elderly. So when we think about those in their 60s or 70s, their 80s and their 90s, this is where we see that case fatality rate start going. It should be 3, and it should be 70 to 79, 8%, 15, 25. And of course, those living in our long-term care homes have a much more significant risk of dying because they tend to be frailer, tend to be older, and having chronic illnesses. So we're seeing rates of death as up to 1 in 3. So just a few things to kind of put COVID into context. And I'm going to show you, the timeline in Ontario, because that's the context that I know the most. But all provinces and territories, and of course across Canada, there's obviously a similar story that you could tell using a similar timeline. And this reminds us that it was only a few months ago when we were starting to take COVID seriously, as it was really starting to kind of march around the world. And of course, Ontario had its first case of COVID on January 25th. And then we had our first death of COVID on March 27th, and our first deaths in our long-term care homes on March 21st. So, on March 24th. So we're only talking about a few months ago when we had our first deaths in our long-term care homes. And above the line, you see the public health measures being taken when we started implementing our lockdowns and our other restrictive measures. This is looking at the epidemic curve of COVID-19 deaths. And this is looking from since the 5th death that we've seen. And of course, many of you have seen these curves and this notion of flattening the curve, and how the idea that measures we could take to promote physical distancing and isolation could try and help bend that curve. And you can see Canada's marked by the red line. We have various provinces that are noted, including Ontario in the light blue. You see some provinces like BC and Alberta were doing spectacularly well compared to other parts of the country. And of course, you have the context of places like New York or South Korea and Italy, for example, and see how they were actually experiencing better and worse outcomes than Canada overall. Many people saw these modeling curves that were being presented, and this is where we were talking about best case scenarios versus worst case scenarios. And of course, we were using the Italian worst case scenario, the South Korean best case scenario that's marked in the blue, if you will. And of course, we were saying that in Ontario, for example, the red dotted line shows what our normal ventilator capacity or our ICU beds actually were versus what we were willing to actually expand to create. And we were hoping that our Ontario scenario would see us just barely cross that red dotted line if we took appropriate measures. The good news story is Ontario, just like most of Canada, we never saw us actually stressing our hospital system altogether. In fact, we did such a great job as Canadians physically distancing and isolating and putting in our lockdowns earlier than other jurisdictions that we actually saw that purple line is what we actually saw, where we actually had a better outcome than, say, South Korea did overall. And so that's the great news story. The story, however, in our long-term care homes was anything but great. So this is actually showing up to April 18th. So you remember I told you that by March 24th, we had our first death in the long-term care home. And then by April 15th, we had 367 deaths in our long-term care homes and about 1,533 or 2,500 cases amongst residents and staff. Well, I can tell you that now in Ontario, we have 10,000 resident and staff cases, and we just crossed over 2,000 deaths. And again, this is just in a matter of months, if you will. So it just shows you how we haven't been as successful in our long-term care settings. In fact, when you look at Canada versus the rest of the world, for example, this is another example where we're an outlier, where we actually have the highest proportion of deaths occurring of any country that we've compared ourselves to around the world, where our deaths have actually occurred in long-term care homes. And this red arrow is pointing to 78%. This was a piece of work we published, the NIA did in partnership with the London School of Economics, where we showed that Canada's rate was about 78%. And now it's about 80% today. It was as high as 85% at one point of our deaths being in long-term care or nursing and retirement homes across Canada. And of course, when we think about where outbreaks live, we know that outbreaks of infectious diseases, so this is 5 years worth of data in Ontario, and you can see our nursing homes in Ontario, or what we call long-term care homes in Ontario, versus our retirement homes. We see that we actually see 3 times the number of deaths occurring in our long-term care homes versus our retirement homes, and 7.5 times the number of deaths occurring versus, say, hospitals. And so we see that we often see more outbreaks happening in nursing homes versus, say, retirement homes. And partly this is due to the fact that people living in nursing homes or long-term care homes in Ontario tend to be older, a little bit older, tend to be more frail, tend to have more chronic issues that require this level of care, and are almost twice as likely to be living with dementia. But people living in long-term care homes in Ontario are more likely to be living in multi-bedded rooms. 2, 3, and 4-bedded rooms were virtually unheard of in the privately run retirement homes in Ontario. So again, you see, this is kind of giving us some evidence as to why we see outbreaks more common in these residential settings, but certainly not to the level of deaths that we've seen under COVID-19. So what we realize is that COVID-19 is anything but a typical virus. So we know that there have been increasing reports of its ability to present atypically, including asymptomatically as well. And by March, the end of March, we started having major publications like that in the New England Journal of Medicine, which was actually showing the epidemiology of COVID in nursing home settings in the United States. And these were studies being published by CDC officials, which showed up to 50 to 75% of positive cases in these settings were being found to be asymptomatic or pre-symptomatic cases. So COVID-19 is not like influenza, which actually has vaccines available and effective treatments available to kind of limit the death rates. So on a typical year in Canada, we have maybe just over 1,000 people who die of influenza, and we've already had 8,000 deaths in our country from COVID-19. And so this is why we knew that we had to actually treat COVID-19 very differently in long-term care settings. We had to restrict non-essential visitors. We had to put in universal masking policies. We had to test and isolate any positive contact, and not just those people who look symptomatic. Ensure that people working in these environments or visiting these environments know actually how to use their personal protective equipment, and then how do we provide excellent and supportive care. And I'm proud that I was asked to review, the Public Health Agency of Canada asked me to be their expert reviewer of the new guidelines that should be released shortly about how to provide care for people with COVID in a long-term care home or a nursing home. And that guidance should be out shortly. So Canada's responses have actually been quite variable. Just like Michael was noting that basically every jurisdiction organizes its long-term care services in different ways, we know that every province and territory has acted differently at different time points. And so the idea that stopping non-essential visits, preventing staff to work in multiple settings, masking all staff and visitors, and implementing COVID-19 infections, for example, and creating more flexible admission and discharge policies. This is what we've called our iron ring guidance for protecting older Canadians in settings across the country. And we released this on March 27th, but we've seen a variable time points of reactions at the provincial and territorial level. So I had the Minister of Seniors federally call me on April 2nd because I was quoted in a Globe and Mail article by Andre Picard, where he basically quoted me and started his article by saying, Dr. Sinha says that if his mother was in long-term care, he'd pull her out. Well, my mother's happily aging in her own home in Winnipeg right now. And of course, that got the attention of many, including the federal minister, who said, clearly you're not having much faith in our long-term care system to protect older adults. What could the federal government do? And I said, well, one of the things you could do is create federal guidelines, because I see variable responses happening across the country. And so within 6 days of that call, we had the launch of new federal guidelines. But of course, the federal government can only recommend things. They can't actually mandate things, although rather under emergency measures, they probably could, but that's a different story. So you see, and in our guidance document there, we actually point out when every province was taking various actions. You'll see BC, I want to point out, for example, is a province that actually took quite definitive actions quite early in the COVID-19 pandemic, especially around supporting people in long-term care environments. As a contrast, I give you Ontario's more delayed responses and actions. And you can see that we have even a month go by in terms of limiting care providers and working in multiple settings, something that really was credited with BC's success amongst other measures. But what I want to remind people was that when we only had a few hundred dead by the end of April, if you will, and now we've had 2,000 dead in Ontario. You can see that days matter in a pandemic, and days actually can cost lives. So this is the data from our COVID-19 long-term care tracker that we developed, and I've just highlighted for you Ontario versus British Columbia. You can see that Ontario has 1,396 homes, BC has 392 homes. We've had about 30% of our homes in Ontario experience outbreaks now, compared to only 10% of homes in BC. And we've had about, and you can see the number of staff cases and the resident cases, but here's the difference. BC's had only 93 deaths in their long-term care and retirement homes. Ontario's just crossed over 2,000 deaths in total. And overall in Canada, we're looking at a 37% case fatality rate. And similar case fatality rates in Ontario and BC, but significantly different responses. So it's interesting now because BC's actually put in an immunity law saying you can't really sue long-term care homes if your loved one died in those settings. I don't disagree with BC, because BC basically said, as long as these homes are actually following the guidance, you know, we don't want you necessarily to sue unless there's gross negligence. Ontario is now contemplating that, because you can see the deaths that we've had in Ontario are staggering. But of course, you know, the question is, if, you know, the homes are said, well, you can get off because you were following the Ontario guidance. Well, remember, Ontario's guidance was much further delayed than BC. And the question is, we're now starting to look at passing immunity laws before we actually launch a commission in Ontario to actually understand what went wrong. So I just point those out. So just to finish off the presentation, I want to remind us that we can't fight a fire blindfolded, and you can't monitor what you don't measure. So in early April, the NIA established its COVID-19 open data working group, which is a team of staff and volunteers that's actually using our time to try and track the reported cases and deaths among staff and residents in nursing and retirement homes across Canada. And right now, as I mentioned, we've had 5,800 homes across Canada, and over 1,000 of them have actually experienced these outbreaks. And the goal of our tracker is to strengthen frontline activities that can benefit those living and working across these settings. So this is basically what it looks like when you go onto our website. So you can see every home in Canada that's actually experienced an outbreak. And you can see kind of what it would look like, for example, when you click on an individual home. So this was done a little while back. This home is now no longer an outbreak in Kelowna, but you can see how we report that information. And we've been we've had thousands of visits to this as well. So my lessons to date are that COVID-19 is here to stay for at least 18 months. Why do I say 18 months? That's our great hope, that we might actually have a vaccine, but we yet to have a successful coronavirus vaccine developed. We haven't developed a vaccine yet for SARS that hit us hard in 2003, 2009. We need to do better to protect staff and residents, as too many are still facing unnecessary outbreaks, illness, and death. Actions have been encouraging, but we still need to do more, including considering how a lack of space can facilitate the spread of, and our ability to control infectious diseases and outbreaks in long-term care settings. And we certainly need to ensure that we use what we have learned as an opportunity to change Canada's long-term care system for the better once and for all. When we think about design considerations across care homes, this just gives us a future aspect of what we need to think about, because many homes that have been experiencing outbreak that have multi-bedded rooms say, should we just keep filling up the beds and hope for the best moving forward? And really what we need to think about, how do we actually develop facilities in future where we might want to care for loved ones? So we always have to keep into account how we can promote physical distancing considerations, because too many homes still have people locked in their own rooms, which is not healthy for anyone. We have to make sure that we have easy to clean surfaces and furniture. We have to have fewer 2, 3, and 4 bedded rooms and better multi-room layouts, for example. We have to make sure that we have smaller footprints, so pod-like settings where a smaller group of people are living in a common area, if you will, and that allows common staffing as well. And remembering that these are first and foremost homes, and we have to respect them as such as well. So what's in store for long-term care? We've yet to have a pandemic without a second wave. So in my view, it's not a matter of if, but when that will happen. As the first wave of long-term care outbreaks resolve, do we have the right provincial regulations, policies, and supports to limit future outbreaks from occurring? We need to find a better way to reintegrate families, friends, and caregivers back into long-term care settings for the benefit of their loved ones. And it's good to ask questions to find helpful answers. And that's why I think we're hearing about a number of inquiries, commissions, or Auditor General investigations that are being launched across the country. And a conversation needs to be had to begin at the provincial territorial level to determine how we should approach the future provision of long-term care in Canada, not just thinking about getting through COVID, but I think answering some of the questions that Michael had highlighted that our work has been doing since the past year as well. So this is where you can find more information, and then I'm going to stop talking so that Dan and the team can take over with a Q&A.
Dr. Sinha and Michael, I just want to say a special thank you to you for your presentation. It was really interesting and thought-provoking. We do have several questions that have come in under the chat function, and I want to encourage others now in this Q&A portion to submit your questions to me. What I'll do is I'll start off by opening it up and giving you the first question. Just take me a second to get there. One of the questions has to do with per capita spending. And Michael, this probably is yours in terms of the comparison between Canada and Denmark. If you were to age adjust, what's the per senior spending, and how do they compare? How does that spending compare between Canada and Denmark?
Yeah, that is a great question. I have actually engaged. I would have to take a look. I don't have that number off the top of my head. Perhaps Samir does, but happy to follow up with that answer once we can find it.
Excellent. So Christian Josephson asked the question. Heather has a question. Family as essential care partners are often excluded from decision-making in long-term care, all the way from shared decision-making with daily care to organizational design of care. COVID-19 has resulted in a regression to institutional-centric care at a time when residents and family-centered care is paramount. What policies are needed to ensure family care partners are involved in long-term care redesign nationally, provincially, and within individual facilities? So I'd like to put that question forward to either of you.
Yeah, so I'm happy to answer that one. And so, I mean, I think the first of all, the issue is that, you know, you can't make good policy without involving the people who actually it will affect first and foremost, and that's the residents themselves, but also their family members and care partners, if you will. And I think this has really exposed a lot of things, because as we've been quickly trying to pivot, especially in long-term care homes during COVID, I think a lot of people with good like policymakers with well-intentioned premises have said, well, the first thing we need to do is we just need to lock the doors and not let any family members come in, because really they're only there for social purposes, which we realize is not the case. 75% of the care that's actually provided in Canada is actually unpaid care by family members. And what a lot of people underestimated was the fact that family members weren't just coming in for social chat with mom and dad in the home. I often will convince family members who are about to lose their own lives, due to the stress of caregiving for a loved one. I sometimes have to strong arm family members, daughters or sons, to finally accept to have their loved one go into a home, because it's going to kill them otherwise. And I remind them that this is about allowing, the home to provide the care, but this doesn't stop you from being a partner in that care and providing things in a way that won't kill you and will lead to the best benefit of everyone. So often a lot of my patients who've moved into long-term care, that has not stopped their family members from going in and still feeding their loved one 3 times a day, maybe bathing or dressing them because they only feel comfortable. And so what we're now seeing is that in Quebec, where they actually lost 10,000 frontline workers in these environments, is because they just couldn't they lost the trust of their workers. And people just said, I'm not going to come and work and risk my life, when most of the health worker deaths in Canada have occurred amongst care providers. So they actually opened the doors, and rather cynically, to allow family members to come in and actually provide care, because frankly, if we didn't allow them to do that, then nobody would be providing that care, if you will. So now we actually have this whole new issue that we're opening up long-term care homes and retirement homes for visits. But now, of course, we've said in Ontario has decided to be a world leader in creating the most restrictive guidance, and that are not, again, respectful to family caregivers and partners, for example, families who want to visit. So for example, Ontario is the only jurisdiction that we know of in the world that's actually demanding that people have to get COVID tests done within the 14 days of their visit. And then they have to attest when they come to the home that they've had a negative test. So I have my own colleagues, for example, who are physicians, who are now getting their very first COVID-19 test during this entire pandemic, just so that they have the right to be able to visit their own loved one. That doesn't make any scientific sense that we know of. It's actually, and then the other thing too is we're saying, oh, and if you're an elderly loved one where your chance of having incontinence is about 30%, and you're going to visit your loved one at the home, and then you have to go to the bathroom, sorry, you will not be allowed to go in the home to relieve yourself. So I've said to, people, what, so they have to go in the bushes? Like, this is ridiculous, because it's not respecting. Oh, and by the way, in Ontario, we're saying the visits can only occur outdoors, so hope the weather's good, and you only get 30 minutes once a week and with one individual. How is that fair and respectful for family members? And again, I don't know who was consulted. The government's not releasing who was consulted. They say they consulted with experts. None of the experts I know say that they were consulted, and I'm pretty sure that no families or residents were consulted about this either. So it just shows you how it's another classic example how we do a very poor job of engaging families and residents, and we need to put them at the heart of this. And that's why we talked about our policies, our enablers, saying the first one was about a person-centered and family-centered system of care. That's where we have to start reimagining the future of long-term care.
It's a great question that Heather posed, and it strikes me that we talk a good talk when it comes to person-centered care, but then when the rubber meets the road and a crisis occurs, we can't just simply set that aside and now for something completely different. So these are really important discussions to be had, particularly when we're debating measures that may actually take what we have to be home-like and make it more institutional, more hospital-like, given the impetus to do that, to try and fix one problem, unfortunately creating a number of other far more significant problems. So let's see, we've got Sheena, Michael, Sheena has written just to clarify some of the numbers for New Brunswick. So I just note that for you in the chat.
Yeah, I think we had chatted about that. It's a typo, but she's absolutely correct. You'll notice that Newfoundland and Brunswick have this.
Excellent. So Sheena, good catch. Michael McFadden writes, what do you advise regarding visitors and having visitors come into facilities?
I don't know if there's a more specific piece on that, so I'll just start. But if there's a more specific aspect to that question, so right now, you know, what we're saying is that for visitors, for example, they're being allowed across Canada, if you will, and what they're doing is they're trying to everybody's now, because of enough pressure on social media, and I think me being on the news quite a bit complaining about this with my colleagues, we're now starting to see that the government's trying to, you know, kind of pivot a little bit by recognizing what we call visitors and what we call essential caregivers. So the idea that what we're saying is we're talking about essential visitors versus just visitors. Essential visitors would be deemed as people who might be there because they're there to provide comfort and support for someone who's dying, but also expanding that list to include people there fundamentally to provide care in that way. And so what we're seeing is that classification is being allowed to come into a home during an actual when an outbreak isn't occurring. And during an outbreak, they're trying to say only people who are coming there to say goodbye to their loved ones are allowed in. For regular visitors, what they're trying to say is that's just really there for a social visit. For them, for example, right now across Canada, it's really being limited preliminarily to only outdoor visits. Ontario retirement homes are allowed to also allow people to come into the home, you know, provided that they're wearing PPE and physical physical distancing, all those appropriate things. I just have to note that in other countries around the world, like in the Netherlands, for example, they've allowed families to come in and either do a social visit or other visits, but they just made sure that people know how to use their PPE, that they have the right PPE, they're compliant with infection control guidelines. And what's the result? By treating families with a level of respect like that, they found that no problems doing that. But of course, people are fear-mongering right now, and I think in Canada they're being extra cautious because we've all allowed 80% of these deaths to occur in our long-term care homes, and I think people are very politically sensitive. So I think this is why we're seeing much more restrictive and reactive policies in places like Ontario and in general in Canada than we are in other parts of the world that have showed that if you actually, you know, support visitors and treat them respectfully, they're often there to provide support for their loved ones, not to create more harm and unnecessary deaths.
Connie Snyder asks a very closely connected question. How do you prevent social isolation for those living in long-term care facilities?
So I can start, and if Michael has other points to add. So again, you know, the idea that social isolation, we have to remember that COVID-19 is something that's quite definitive. We can say that this person died of COVID-19 or not. Social isolation is one of those things where how do you measure it? How do you quantify it? But we do have facts that, for example, on World Elder Abuse Awareness Day, just on Monday this past week, we actually, the NIA released some guidance documents around social isolation as it relates to elder abuse, because it can also be a form of neglect as well. And the notion is that social isolation, about 1 in 5 older Canadians is actually experiencing social isolation. Now, social isolation doesn't equal loneliness and depression, but it can certainly lead to that. And if someone is lonely as a result, their risk of dying increases by 45%. And we actually say that that's the equivalency of smoking 15 cigarettes a day. So social isolation is quite common. And again, how do you limit this, right? So this is where we talked about the importance of virtual visits, but actually permitting visits that we can, recognizing that that social interaction with other residents, but also family members is really important. So many of homes have taken such drastic actions, including when homes haven't been an outbreak, where they've actually isolated everyone to their rooms. And that's a problematic feature because 70% of the people in a long-term care home, a nursing home, have dementia, about 50% of people in retirement homes. And often for an older person with dementia, it's that socialization that's really important for them, including the idea that when you go to a dining room and you see everybody else eating and you see how they're actually eating itself, that actually puts a cue in our brain to remind us it's time to eat and how to eat. Those cues all get lost when you're sitting in your room and someone puts a tray at your feet and expects you to figure things out. That's why we've been seeing increasing risk of people not eating, not hydrating, and that. And I'll leave you with this. There was a recent study that just came out of France where they actually they called this confinement disease, where they actually found in a home that had an outbreak of COVID-19, they found more people in that home under these strict isolation measures died of what they call confinement disease, dehydration, a lack of social interaction, than died of COVID-19 itself. And I think when the numbers are out in a year and we look at the actual deaths that have happened, I told you that over 2,000 people have died, or over 2,000 people have died in Ontario homes from COVID-19. We may have twice as many people who've died from or have had excess deaths due to these aspects of what I'd call confinement disease as well.
We often forget that we're social creatures and that at the heart of how we're wired, it's to be with each other and amongst each other that brings quality of life, but also you mentioned the communal benefits of triggering eating, for instance. We break bread together. So Carolyn asks, Clubine asks a good question. It seems our communities are now experiencing fatigue in maintaining the correct behaviors for social distancing or physical distancing. She's particularly concerned for the staff in long-term care, not just during hours, but after hours as they congregate, and we see more and more people in groups and relaxation of the past heightened awareness. So any suggestions for staff, messaging for staff?
Yeah, so it's actually very interesting because in Belgium, in the Journal of American Medical Association, they just published a spectacular study where they actually tested pretty much 75% of the hospital workers, and that not just the doctors and nurses, but also volunteers and administrative staff in that setting. And what they actually showed is that there was a greater risk of getting COVID-19 from an exposure in your own family or community than actually working in a hospital where there were several COVID-19 cases. So it reminds us that in these environments where we're trying to keep them sterile, where we're now finally giving homes access and workers access to PPE and making sure that they know how to use and practice good infection prevention control guidelines, it's probably safer for these folks, these workers and their visitors, being in these homes than it is out in the community. And so obviously we're worried that as we now relax things, and if we relax things too early, COVID-19 could spread. And the people we're most worried about getting this are the workers themselves, but also visitors, who could then bring it into the homes. That's how COVID-19 got into all these homes so easily. It was often workers who were bringing it into these homes. And remember that when we built an entire long-term care system on the backs of racialized women who are trying to make a basic wage, many of these folks are not living in big fancy houses with plenty of space to isolate from other people. Often, if we look at the data in Toronto, we see that basically people who are living in crowded housing are more likely to catch and spread COVID-19 to others. Those are the neighborhoods and those are the houses where we're seeing this. And this is where many of these these folks working in essential roles across our country are living. So is there a reason to be concerned? Absolutely. But is this a reason so is this a reason why we have to be mindful as Canadians about practicing physical distancing and doing our best? Absolutely, and especially for those workers and visitors coming in. But this shouldn't actually force us to do things that become onerous or particularly target these individuals in a negative way or make it hard for families to visit their loved ones in care.
I'll only add that, you know, from a public policy point of view, not being the medical expert that Samir is, I think the other thing that COVID has taught us, and without, you know, pointing a finger at anyone, is that it's a huge responsibility from the point of view of government and public health to communicate consistently and clearly to the public. And I think, you know, the world across, we've seen a lot of back and forth. And again, we're dealing with the disease, especially back in February and March, where we didn't know much. But I think a lot of the fatigue coming from the public in terms of compliance is that it's been hard to understand what the sort of simple steps are to keeping yourself safe. There's been some contradictions. And then of course, you know, you get media bleed over from across the world, different jurisdictions approaching things differently. And I think, you know, if we have a sort of collective lesson to learn for future scenarios, as unfortunate as they might be, it's the consistency of public messaging has to improve over time.
So, Michael, I've got another question that I'm hoping you can kick off with, and that's from Deb Egan. She asks about the jurisdictions that are doing particularly well. And when this is where the question is, where are the best resources that balance risk and family connection with guidelines for visiting? The latest guidelines in Ontario appear very restrictive. So what jurisdictions have you seen that have gotten this right or better than Ontario?
Yeah, I mean, I hate to defer another question to Samir, although I may. I think in Canada, it's hard to say, right? Because when we're looking at the numbers, including this chart that's open right now, we're seeing a disproportionate effect of COVID in Quebec and Ontario. Both of those provinces are struggling with visitation policies. And it's hard, you know, from a certain perspective to disaggregate what the effect is when you're dealing with a large outbreak of COVID in some of these provinces compared to another province where the spread maybe wasn't as urgent, wasn't as feverish. It becomes easier, again, to my previous point, to sort of communicate and deal with a lot of the vagaries. I'd say in Ontario, just, you know, looking across the board, whether we're talking about family visitation or other provinces, British Columbia consistently pops up to the top. They've taken a completely different approach, which, you know, going to the top of this presentation says something potentially about the preservation of provincial jurisdiction in these areas. I certainly might, in our institute, we'll talk about this and we'll consult on it. But, you know, when you're looking at a case like British Columbia, where early on they took decisive, quick action, whether you agree with it or not, there's probably a case to be made in that jurisdiction about fundamentally nationalizing the services earlier on, taking the reins. I don't know that anyone's perfected any one aspect of this, but it's clear that Quebec and Ontario are struggling across the board, where British Columbia has done somewhat better. And then internationally, you know, the examples are, you know, we're sort of expanding the scope now of the conversation, but places like New Zealand, South Korea have done particularly well, but for different factors, right? In South Korea, they're doing a lot more testing early on, the heat mapping. You know, New Zealand has the benefit of being an island that shut down its borders very quickly, but there's a lot of factors to unpack. And I think in Canada, no one's done exceptionally well, but British Columbia probably leads the pack.
Yeah, and just building on just building on Michael's comments, right? You know, what we've really seen is that after SARS, we had our federal commission, we had our provincial commissions that actually taught us a lot of things that we should be doing, like making sure we have ample supplies of PPE available. And many provinces that fell short and actually delayed their responses, they just didn't have ample PPE stores, and nobody knows why exactly, but it clearly wasn't a priority to make sure that they were amply fully filled, which was a lesson that we said after SARS, never again. And then we were repeating lots of the same things. So because we didn't have ample PPE supplies and we took delays getting our testing capacity set up, especially in Ontario, so that delayed a huge amount of responses or even our willingness to actually allow people in these care homes. And so it's kind of the one delay after another and not actually being set up for success in the first place, then delaying key responses. And, you know, for example, it was made public in the Toronto Star. Someone leaked an email of mine that I sent to the government that actually showed that on March 27th, I said, this is what we need to be doing. It was the same date that BC took their definitive action, and the government didn't act on my recommendations until April 15th. Again, that was their choice. I'm not the one who makes decisions. I just provide advice. But again, it showed that we then ended up having a situation in Quebec, Ontario, where our long-term care systems like largely collapsed. It's why we had to bring in the army. It's why we're desperately trying to recruit workers. In fact, reassigning people from school boards to work in these homes. We've had to compel hospital workers to go into these. So we've really seen what happens when things go wrong. But I'll go back to lessons from SARS. So Hong Kong, Taiwan, Singapore were jurisdictions that were hit hard by SARS as well, just like Canada was, but they learned from those lessons. So how many deaths have occurred in Taiwan in long-term care homes? 0. How many in Hong Kong? 0. Only 2 deaths in Korean nursing homes, and those occurred in hospitals. And then in Singapore, I think it was about 3 deaths that occurred in these homes. So, and I'm talking about like less. I've counted less than, you know, my fingers, and I don't even have to bring in my toes into this matter. And then in Canada, we have this dubious distinction of 6,612.
Yeah, actually, and Samir, you might have the numbers on this, but I think sub-jurisdictionally, Kingston, Ontario is going to be an interesting case to study in the future. They seem to be a little bit of an island even within Ontario in terms of the outcomes. And to Samir's point about inspectors, Kingston decided to redirect food inspectors and other professionals right at the start to get ahead of the curve, make sure that everyone was complying, that things were on top of things. So even within Ontario, we see this little island in Kingston, Ontario that's done exceptionally well.
Mm-hmm. Very interesting. And kind of in that spirit of searching out positive deviance, you know, we're looking for solutions, we're looking to other jurisdictions, but somewhere someone has done some remarkable work. And if my work in Canada is any reflection, we usually don't brag much, but there's some innovation that's going on in long-term care that isn't being talked about enough. The steps that have been taken to overcome social isolation, the steps that have been taken to protect residents, and the work that's going on. I mean, some pretty incredible stuff that needs to start to be shared. And I think we would love to be able to figure out, and maybe the Institute is the platform to start to share promising practice. We, if there is a second wave, we owe it to ourselves to come out and share that promising practice and do better the second round. Now, I want to go through, the questions are stacking up. We're doing really well, and we may have to figure out a way to get you to go back and forth with some of these after this session. There's a question that Trish Rothorn raises, and it has to do with the, you know, kind of that switch you talked about, Michael, with Canada versus Denmark, where it's not quite the inverse, but they have far more in Denmark, far more of a investment in community care and home care versus facility care. In Canada, it's almost the reverse. We have far more in facility care than we do in home-based services. Now, if there's a desire legitimately to make that switch, how do you figure out the funding so that that switch actually occurs? We have had, and this is my own editorial comment, we've had too many examples where we've deinstitutionalized and failed to make the proper investments in community to be able to prepare and ready the community for care. So any insights into the how? Would it be direct funding to municipalities from the federal government? Is there a way that this change can happen?
Yeah, I mean, I think there's a number of options. I think the place to start is that we can't go into it blind, right? So the reason with our original series, the pre-COVID series, the reason we carved it into the sort of health policy aspect of it, the deep work that Samir did, and then the sort of analysis that Bonnie Jean did, was that it's one thing. And I think, you know, here in Canada, sometimes we have a penchant to sort of think big in terms of outcomes and policy, without considering how to tie the knots properly on the fiscal funding side of things. And as anyone who's worked in government knows, the policy on the ground has to merge with the amount of money you potentially have in the coffers. So I would say that the first thing, we are doing that analysis actually right now, speaking in terms of second stages of things. We're actually going to continue to build on our series, given COVID, to better understand how we could approach new models of care. And shifting into home care is a fundamental drive. It's something we're going to look into. I'd say even looking at Denmark, there's a promise that if we can get it right, there might be upfront investments where we sort of have to spend disproportionately to build up the capacity in the system. But over time, there is the promise that you could start seeing the cost curve bend. We've seen that in other jurisdictions. Because quite simply, you know, if we could do a lot of the good stuff, the preventative care, we haven't talked about it, but Samir's policy on reablement, which is essentially, can we, you know, help people stay independent for as long as possible? And that doesn't just mean in their home, but it means physically, right, in terms of their actual bodies. That if we can do more preventative medicine, more engagement at home, more proactive steps. Another little thing that comes out of the Denmark comparison is that, Samir, correct me if I'm wrong, but I think when you turn 75, you automatically get a visit at home from a nurse. They'll do an assessment, they'll check up on you, and then they'll come back once a year. We have nothing like that here in Canada, but it helps you sort of catch problems before they arise, manage individual health challenges. That feeds into systemic issues. So, you know, it's a big challenge. I don't know that government's going to be able to fund all of this, quite honestly. I think we're going to have to continue looking at public-private partnerships. We might have to look at social insurance models. Countries like Germany, for example, Japan, they have long-term care insurance models that are shared, similar to the Canada Pension Plan, where the public pays a portion of it, employers pay a portion of it, but then your costs are covered completely. You have choices and flexibility within that model. Australia is moving to something more like a direct funding model. So what I would say about those is that those are mechanisms for how we could potentially pay for care. But the first thing we have to do is get a firm grasp on how much an ideal practical system would cost, and then start approaching what tools are at our disposal to pay for that. But again, going back to Bonnie Jean's report, if we're looking at a tripling of costs with the current system, it's not clear to me that we're not going to need such an amount more that it's going to be able to come strictly from government coffers.
I think, and just quickly, just building on Michael's comment, like what we did in Ontario, for example, is we were spending more on nursing home care in Ontario than we were on home and community care. And so under the senior strategy that I helped develop back in 2012, we actually started increasing on a year-over-year basis, 2% increase in the nursing home budget, you know, to meet the inflationary target there. But we started actually increasing the home and community care budget by 5% year over year, which meant, you know, a few $1 billion more into home care in Ontario. And by doing that over a 5 to 6 year period, we were now supporting more nursing home eligible people to live in their own homes with more adequately funded home care than actually were living in nursing homes themselves in Ontario. And so that was something that the Ontario government did a terrible job actually telling the story of, because it was the idea that we could actually keep more people in their community. But again, it's a deinstitutionalization model that works fundamentally when you actually appropriately fund alternatives, which are much cheaper than building expensive facilities, and then that you can't even staff appropriately. So we have made some success so that Ontario is the only jurisdiction where the home care spend outbids its nursing home spend compared to the rest of Canada, where you have that sharp contrast. But still, we still significantly underinvest in Ontario what we do in home care and nursing home care compared to what we do for our hospitals or our other budget lines in health.
It's excellent. Nathan Gomez, his comment really talks to, and his question really speaks to the issue of sustainability. But specifically related to unemployment rates around seniors that are 55 due to COVID-19 is about 9.5%, with millions losing their retirement savings in the market collapse. Long-term care obviously is not free. What measures can be put in place to ensure that individuals can afford the copay? And Ontario taxpayers are to pay for long-term care costs without substantial income or property tax increases. In other words, we have, and I think, Michael, you addressed many of these with different policy options, but we have an affordability, not only on the government side, but given the impact to individuals, their ability to even afford the copay on long-term care, institutional care, is really at question. So I'll leave it as more of a comment, Nathan, just given the time.
Well, I don't mind stepping in just a little bit. It won't answer the question fully because it is a big one.
No, please.
But this is, this is a part of what the NIA has been set up to do. So the healthcare system can't solve the individual income side of things, right? This is why we, as a society, governments, institutes, have to take a holistic approach to things. So Bonnie Jean right now, Bonnie Jean McDonald, Samir's counterpart on our financial side, is engaging an entire batch of work to look at how Canadians can make better use of existing funding sources. For example, the Canada Pension Plan. If you wait until you're 70, as opposed to taking it at 60, you have that choice. You can take it as early as 60, as late as 70. You can get up to 200% more in benefits indexed for life. Most Canadians don't make that choice. In fact, they take it early, oftentimes on bad advice from personal financial advisors who might not know better. But this is one of those things where the healthcare system, long-term care in particular, is catching up to demographics. But even on the financial side, whether it's personal in terms of government benefits, I don't think all of us as individuals or even families have internalized the fact that we're going to live a lot longer than we used to, right? I mean, retirement in terms of managing your finances used to last about 5-10 years. Now we're looking at trying to make whatever meager savings Canadians can cobble together last for 30-40 years, right? So this is, again, underlying all of this is a massive fiscal and personal financial paradigm shift that'll have to take place. The old models of retirement planning, the old models of long-term care, we have to turn the chapter on that entirely and move forward in a holistic new way.
Debbie asks if there's any group that's forming an advocacy effort related to family visiting restrictions.
Right now I don't know of any in any kind of federal, provincial. We're certainly in talks with a number of groups, and we're actually looking at. We're currently working on a piece of work right now, actually creating kind of. I was talking to the folks at PHAC this morning, saying, can we not change our guidelines, our infection control, or the new long-term care guidelines to include that? And they said that's kind of not their mandate at the moment. And I said, okay, fair enough. So, but they basically gave Michael and I the green light, so that, again, in partnership with various family and caregiver organizations, we could say, look, this is what practical guidelines would look like based on international evidence, so that we can take the restrictiveness out of Ontario and kind of reach the practicality that other jurisdictions that have been doing a better job have figured out already. So.
Michael McFadden writes, as care providers, we're struggling with moral distress at helping people to stay alive, but having a hard time assuring their reason for living, which is so often family and friend connection and socialization. Any comment on that? I mean, that's really a particular theme that's showing up here this afternoon.
Well, I think this is kind of that notion. It's a great question, because I think it really, like, at the heart of this, we have to remember that there are 425,000 Canadians who are currently living in our over 5,800 homes. The vast majority of these are older adults. Over 400,000 of them are older adults, and probably within the last 18 months of their lives, for example. So we know that people who move into these homes have quite limited life expectancies, but it doesn't mean that they don't have a quality of life. And often, if you have restrictions on your mobility or your cognition, it is those essentially family visits that are kind of the reason why you're hanging on and enjoying what you can, or where you derive some quality from. So I think in a lot of this, I think, people, deaths are very inconvenient. They're not very good politically to get reelected. And I think people are taking actions, forgetting at the heart of this are are hundreds of thousands of older people who just want to have quality and dignity of life. And so I appreciate the moral distress that their families are having, families who can't visit their loved ones and provide that support. The older people themselves who are saying, what's the point? If I can't visit my loved ones and I can only visit them in these restricted ways, you know, why am I hanging on for what? And for care providers who are caught in the middle, you know, who don't really want to see so much undue suffering happen beyond the virus itself. So this is not an easy thing, but I think this comes back to, what do residents want? What do families want? How do we, and then how do we think, using a harm reduction approach, a way to try and permit quality of life to be preserved in these difficult times?
There's some very good questions that have been posted, and unfortunately we're running short of time. I want to point out to those of you that are watching the recording or are able to consider what Andrew Teasdale has to say about complex systems. Margaret talking about Australia and their systems. There's a question about, or lots of comments and observations around regulation, caregiver restrictions. I think we've hit on something here. And there's no doubt that COVID-19 has brought this to the forefront. But what we have is a crisis that calls for a much larger conversation about what needs to happen. Obviously, in the short term, we need to deal with the pandemic at hand. But the next wave, the future, how we deliver care is something that was in question before the pandemic ever happened. It is now our obligation and opportunity to think through and make sure that we question that the way Canada has delivered seniors care and that full continuum of long-term care is not a given, it's a choice. It's a policy. And we have an opportunity here, given the openness of governance for reform, to be able to make sure that that is evidence-informed, that it's an opportunity to really see the changes that are needed. So I want to thank Michael and Samir for your presentations and for your insight. Also the audience members for joining us today. I want to let you know that if you enjoyed today's presentation, you're encouraged to join us for upcoming presentations in our COVID-19 lecture series. So on June 23rd, we have a session on industrial policy for Canada in a post-COVID world. Our panel will examine current trends and changes in technology sector and geopolitics, and will offer advice on how Canadian policymakers should respond. On June 25th, the path to a vaccine for COVID-19. This one touches all of us. Our panel will consider the legal, policy, and ethical considerations when developing a vaccine, including the role of open science, emergency use, and clinical trial ethics. So those event details and registration information are available on JSGS's online events calendar. I want you to join me in a round of applause for our speakers. Just use your Zoom reaction option for our panel, and they'll be able to see it if you go down and hit reaction and applause. I want to thank everyone for joining us this afternoon. Everyone have a wonderful afternoon. Thank you so much.